Hello viewers, today I am going to teach you how to examine a hip. I have already uploaded examination of other parts of the body, so I would recommend you to watch that. Now this video is slightly different to the other videos, as this video is also meant to give you the right information so that if you are appearing in any orthopedic exam across the world, then this video will be useful in understanding and presenting your long cases in the examination. So whether it is a master's examination in India or FRCS in England or any other orthopedic exam, I will try to make this video in a way that it is immensely useful in your examination as well. So now, as I have shown in my other examination videos, that history plays an important role, whether you are seeing a patient in clinic or you are presenting or taking a history for an exam in orthopedics. So if somebody presents to you with a hip pain or problem related to hip, you need to take a thorough history, because that will narrow down your differential diagnosis and it will make your life much easier. And same will happen in exam. So I have just noticed it down here. So I think the first thing that you need to start with is, of course, age. And this is because we know that certain disease are far more common at a certain age. So if there's a young kid who is presenting to your clinic with a groin pain, will have a very different diagnosis to somebody who is a 60-year-old gentleman. So age plays a very important role. Then you need to ask the sex. Certain diseases are more common in males than in females, such as Perthes or Sufis. You will see usually they are more common in male kids. Occupation also has got an important role. So if occupation, somebody has got a sitting job, is very different to somebody who is a laborer. So if you have an old patient or somebody who is in 50s or 60s with a hip pain and he is a laborer by profession, and if you want to do a hip replacement on him, it will have a very different bearing to somebody who is having a sitting job. So a hip replacement for a laborer might not be a good option, because then he needs to change his occupation. So occupation is also important. Now certain groups of race is also important. Certain diseases are seen much more common in different races. So I have worked in England, I have worked in India, and we all know that hip arthritis is far less common in India than you will see in Western or Caucasian population. Now these are the demographic data that you need to catch, and once you have caught the demographic data, and somebody who is presenting with a hip pain, they usually present with 5 or 6 common problems. So I have listed it here. So you have pain, you have limp, you have deformity, you have stiffness, you have limb length discrepancy, you have clicking, catching, or swelling. Swelling is uncommon around the hip, but still they can sometimes present. So let's talk about each of them. So pain first. When you are talking about the pain, you need to drill the pain really well. If you are giving exam in Indian setting, that is important. But if you are appearing in FRCS, you need to drill the pain, because pain, as soon as you drill the pain, you get deep into the pain, you will understand what kind of pathology or what you are dealing with. So onset is extremely important. That when did this start? When were you normal? So if somebody was normal 3 months ago, then you need to have a very clear indication that when did it all start. Then site is extremely important. Now patient presenting with hip problem usually will say it hurts in my groin, or they will sometimes say it hurts in my buttocks. Sometimes they can also present with pain across the lateral aspect if they have trochanteric bursitis, but usually pain across the hip, patient will complain of pain in the groin or in the buttocks. Now, there are occasions when patient, if you ask them where does it hurt, they will put their hand like a C, and this is a positive C sign. So C sign is nothing but thumb on the groin and fingers on the back or the buttocks, and this is very typical of an intra-articular pathology. So site is extremely important. Now severity, how bad it is. If you are appearing exam in England, so you should talk about visual analog scale. Even in India, asking a VAS score is extremely important. So how bad is your pain? Where will you rate your pain? Whether it is 5, 6, 7, 8 or 9, that will give you a baseline, and your treatment will then decide whether the VAS is or visual analog scale is getting better or not. Severity can also be assessed in terms of functions, like how far can you walk? Can you walk? If somebody can walk a kilometer, is very different to somebody who can barely walk few steps. Does it? Do you need to use a stick? So does any walking aid is required? So if you can, if somebody requires an aid, that means his pain is probably much more severe. So drill the severity. Then duration is important, of course, that how far or how long it's been hurting. Now radiation is extremely important. That is this pain only here or is it going somewhere else? Now we know that whenever you're examining a hip, you need to ask whether there is any pain in the back as well, because back it can radiate up to the back, or vice versa, back pain can also present as a groin pain. And I have seen patients who had back pain and who had early arthritis in the hip and had a total hip replacement, and the pain did not get better because actually pain was not that bad in groin, it was the back pain that was radiation. Same way, hip pain can also radiate, especially in the kids. If kid is presenting with a knee pain, it is for me a hip pain. So any kid who is presenting with knee pain is a hip pain until proven otherwise. So that you need to keep in mind. Now what makes it better and what makes it worse? So aggravating or relieving factor. So what makes it better, what makes it better, you need to focus on it. Then night cry, analgesia. How much analgesia? Do you require to take painkillers? What painkillers you take? If somebody is complaining of pain but is not on any painkillers, is very different to somebody who is complaining of pain despite taking paracetamol or codeine or tramadol and strong painkillers. So ask how much do they require analgesia, what analgesia, and how much do they require. One common thing that Indian examiners love is night cry. This is not so common or not so favorite in FRCS, but night cry is important. What is night cry? So, if somebody has got an infective pathology and the articular cartilage is damaged, during the daytime pain is there, but it's not that bad. But when they sleep, the tone of the muscle gets relaxed, there is more grinding of the articular surface, and they report more pain during the night time, and this is night cry. So you should know what is night cry. The other important thing that examiner do focus in India is diurnal variation. So what kind of pain gets better or worse in the night, you should know about it. Now when I talk about pain, if you are appearing in FRCS or when you are seeing patient in clinic, two things that are very critical for me is your ADL, is your activity of daily living affected? So if somebody says that I am struggling with my day-to-day activity, I'm not able to walk, I'm not able to, it is affecting my work, I'm not able to play my sport, and despite taking all painkillers, there is sleep disturbance, I'm not able to sleep, that tells me the disease is more severe, and that guides me that the chances that the patient will require an operative intervention is much higher. So activity of daily living and sleep disturbance, if they are disturbed, has got a lot of bearing. Now the second commonest way the patient presents to you is limp. Now sometimes the patient, they don't notice it, but the wife or the husband will say that you are limping, or in the Indian setting even the neighbors will say that what happened, you are starting to walk a bit funny, you are limping. So limping, again you need to talk about the onset, when is it, duration, whether it is painful or painless, because certain limp, if somebody has got pain due to arthritis or inflammatory pathology, they will usually have painful limp. Sometimes if somebody has got DDH or somebody has got polio, they also limp, but then they have what we call a painless limp. So you have to differentiate whether limp is painful or painless, whether it is getting worse. So progression is important, and ambulatory status is so bad that the patient is now wheelchair bound or cannot walk, or the ambulatory status is compromised that he cannot walk or stand for long. So that is also important. Now, the third thing is usually deformity. So where is the deformity? The site, onset, when did it happen, what is the duration, and whether it is getting worse or not. Usually, deformity across the hip is not so noticed by the patients, but they do have deformity, and usually as the disease will progress, the deformity will also progress. Now, stiffness or limitation of movement. This is, I think, the most important reason the patient comes to you to seek advice apart from pain. Now, the stiffness in Indian setting can be easily assessed by functions such as can they sit on low chair, can they squat, because squatting is a very important part of our day-to-day culture in developing countries, especially in India. Can they sit cross-legged? If somebody can squat and sit cross-legged without any pain, and that for me tells me that hip is almost normal. On the other hand, if they are struggling to squat and sit cross-legged, then that tells me that due to arthritis, there is a good chance the movement of the hip is compromised, and hence they are not able to do so. In Western world, this activity is not so important. So if you're appearing in FRCS, two easy questions that I would request you to ask is, do you struggle to get in and out of car? And I have seen a lot of patients when I was working in England that they do change their car. You know, there are people who are fond of sports car, and because the floor of the sports car is so low, when they have hip arthritis, they struggle a lot, and they sell their sports car and they change the car into somebody in which the chair is slightly higher so that they struggle less. So getting in and out of the car, or simple activity like tying shoelaces. Can they bend down and tie shoelaces? If they are struggling, that is also an indication that there is stiffness or limitation of movement in the hip. Now, limb length discrepancy is also the way the patient can present. So whether there is any shortening or any lengthening, that is important. Now, clicking, catching is an uncommon presentation, but still patients can present with clicking and catching, and the usual culprits in these cases are usually either they are having psoas tendon, psoas tendon clicking, internal snapping, or external snapping due to tensor fasciae lata across the greater tuberosity. Sometimes, if the patient has got labral tear, they can also present with some clicking and catching in the hip. Now, swelling is an uncommon finding across the hip, but again, if there is any history of swelling, you should also drill into swelling, that site, onset, duration, whether it is a painless swelling, whether it's a painful swelling, whether it is progressing or it is not progressing, and whether it is single or multiple. That is also important. So these are the 7 important reasons patient will present to you in your clinic with your hip pain, and I think you should drill deep into it if you are appearing in the exam, because that will help you narrow down your diagnosis. So whenever you are taking history for any pathology in orthopedics, there are only few potential etiologies that are responsible for causing a particular condition. So for when you are examining a hip, when you are taking a history, you should try to filter these causes. So they may be in form of a positive history, or they may be in form of a negative history. So the potential causes that usually can be congenital. So somebody who was born with a problematic hip, and this hip continues to give problem in future life. Trauma is again very common. If somebody has got injury to the hip, either as a child or as an adult, that can be a potential cause that the hip is problematic. Now, infective in developing world is extremely common. Not so common in developed country. So keep infective causes in your back of your mind. So the potential questions that you can ask for them is that if they are having any fever, if they have any evening temperature, because the 2 potential or most common causes are either a septic hip due to a bacterial infection, or tuberculosis, which is extremely common in Asian countries. So you need to ask these questions or inform a positive history or a negative history. Now, inflammatory causes are common both in Asian countries as well as developed countries. So history in form of pain in all joints like polyarthralgia, or pain in small joints, especially across the metacarpophalangeal joint, or morning stiffness is sometimes can be a giveaway that there may be an inflammatory cause. Now, tumor or metastatic, uncommon, but somebody who is elderly, who gives history of pain, loss of weight, pain getting worse, there is loss of appetite, then you must keep this in back of your mind, or somebody who has had a treatment of cancer in the past. So these are important history. Metabolic causes, you should ask about metabolic causes in hip. They can present, especially if I say the example that I would like to give is a SUFI or slip capital upper femoral epiphysis, SUFI, which or SCAFI. It's more common in patients with hypothyroidism or patient who have got hypogonadism. So metabolic history can also be important. Now, drug-related, somebody who has taken long doses of steroid, whether it is for COPD, whether it is for any other inflammatory pathology, that is the common thing in developed countries. In India or in developing countries, the most common thing that you will find in young patients is they have taken medication from quack, and they can be for multiple reasons, usually for gaining weight. That is a very common thing, that I took some medication from a quack or a local practitioner who is not medically qualified, and took that medication for long term in order to increase weight. So this is extremely important, because usually they give steroid and they end up having avascular necrosis in future. Now, iatrogenic is somebody which we are responsible. It is not so common in hip, but it can happen if you operate on a 15-year-old or 16-year-old or 13-year-old boy who has got a shaft femur fracture, and if you used a piriformis entry nail, you can cause damage to the blood supply of the head, and they can have subsequently avascular necrosis. Or somebody who had a hip replacement and they come up that now the leg is longer, and that is also extremely common. Or you have increased the offset to an extent that it is led to trochanteric bursitis or lateral hip pain. So these are some causes that I have seen in my medical practice. Idiopathic, a lot of times there is no cause and we classify as idiopathic. So these are the factors that are usually responsible for any pathology across any joints in orthopedics. Now, once you have taken this thorough history and you have taken a positive history or a negative history, then you should ask about the past medical history as well. That will give you some insight that what could be the potential reasons, like any history of previous trauma, or any history of problem as a child, or any history of previous cancer treatment, or any history of long-term drug intake due to rheumatoid arthritis or sarcoidosis. So they can be extremely important. Now, personal history is also important. I think two important things that I ask is whether do you smoke, or how much do you smoke, and do you drink, and how much do you drink. These two things can be cause of avascular necrosis if this has been happening in excess. Now, family history is again important, like history of TB, history of rheumatoid arthritis, history of problem as a hip or CDH, or history of ankylosing spondylitis, or any other inflammatory causes. For completion's sake, in Indian exam, you need to talk about, at least mention about obstetric history or immunization history. It is not so important if you're appearing in FRCS or any other exam in Europe. So once, I think this is the history. If you follow these principles and if you ask the relevant questions, by end of this history, you will have differential diagnosis which will be quite narrow. So after good history, if you are appearing in FRCS or any European exams, then you should do gate first. In Indian scenario, Some examiners will say that leave gait to the end, because if you're not confident, do gait in the end. But in FRCS, once the patient lies down and you ask them to stand again, that will score a negative mark. So I would do gait first. So you should be able to define what is gait. You should have good knowledge about stance phase and swing phase and their different components, and you should be able to describe gait, not only type of gait, but gait in great detail. So you need to know what is foot progression angle. So I have uploaded a video on foot and ankle examination. You can watch that. You should be able to know what is step length, what is stride, all these definitions, and you should be able to describe that when you are examining the gait. Now, in order to assess the gait properly, you should ask patient to walk at least 10 steps. So when patient is walking, you need to comment upon the foot progression angle, whether it is there is a decrease in stance phase, what is the position of the head, what is the position of the shoulder, so that examiner knows that you are understanding the physiology or biomechanics of the gait, and hence you're describing the gait properly. Now there are few different type of gaits that are commonly seen in hips, and I'll show you now one by one. So if you focus on my feet, the first gait that I'm going to describe is what we call is an antalgic gait. So if my left hip is problematic, or left lower limb is problematic, what I will do is, in antalgic gait, the stance phase will be decreased. So patient will try to decrease the movement or time in which the foot is in contact with the ground. So normally, if I'm walking like this, in stance phase, I will, in antalgic gait, I will decrease the stance phase. So the stance phase in antalgic gait will be decreased. Now what will happen to the shoulder? Now if my right hip is having the problem, if it is an antalgic gait, in order to decrease the body weight going through the affected side, the shoulder will go on to the opposite side. So I will try to tilt my shoulder to the opposite side so that the weight is not going through the affected side. So this is antalgic gait. Now the second gait that you will commonly see is what we call is a short limb gait. In short limb gait, you will see the compensatory mechanism. The patient, the first thing is like equinus. The patient may have some equinus, or if the shortening is not that much, the patient will, now on this occasion, will tilt the shoulder to the affected side, because he wants to dip the pelvis and shoulder to the same side. So in antalgic gait, shoulder will droop to the opposite side. In short limb gait, the shoulder will droop on the same side. So short limb gait, the patient will walk something like this. Now you will see a lot of young females and even males, you will see they have got persistent hip anteversion and they walk with what we call an in-toeing gait. So normally foot progression angle, the foot points externally. In patients with hip anteversion or persistent hip anteversion, they will walk with their leg either neutral or with a negative foot progression angle. So this is an in-toeing gait seen in usually persistent hip anteversion. The next gait that I would like to focus is what we call is a circumduction gait. Circumduction gait is seen in patients who have got fused joint or joint in which the hip movement is almost negligible. So what patients will do, in order to clear the ground, they will lean to the opposite side and they will get the leg something like this. So this is a circumduction gait. So it's very simple, because the hip, you have to clear the leg in order to walk. So they will tilt slightly opposite side and then they will do this movement. So this is circumduction gait seen in patients who have got either fused or ankylosed hip joint. So the next gait I would like to focus is, you see this gait in weakness of gluteus maximus. Now gluteus is responsible for extension of the hip. So if my right hip gluteus maximus is weak and I am not able to extend my leg, so the patient will walk something like this in order to extend, and this is the typical gait that you will see in weakness of gluteus maximus. The last test that I would like to cover is what we called is a Tenderloin Gate or waddling gait if the pathology is bilateral. Now this is a test which will also be covered as part of the stability test. It tests the integrity of gluteus medius as well as the lever arm. Now in order to do what happens in the Tenderloin Gate is, for example, if I am standing on my right leg, then I am testing the abductor muscles of the right leg. So normally abductor will work and the ASIS will go up. However, if this is not functioning or there is any weakness or there is a problem with the lever arm, then the ASIS will dip. Now as ASIS will dip, in order to compensate, because this will consume a lot of energy, the shoulder goes on the opposite side and this generates a lurch. And this generates a lurch. And if it's a bilateral thing, then it becomes a waddling gait where patient lurches on both the sides. Patient will walk like a duck, and that will be Tenderloin Gate. Now, I will also like to show you how do you do the Tenderloin test. So let's now focus on how to do a Tenderloin test. Now, there are few trick questions that examiner they ask now remember, if somebody has got a fixed abduction deformity, so somebody who has got a fixed abduction deformity, then you cannot do a Tenderloin test because then you cannot adduct. So if you have got a fixed abduction deformity, then you cannot really do a Tenderloin test. Also, if somebody cannot stand on single leg for around 30 seconds, then again you should say that I'm not able to assess Stendelberg test. So for FRCS, you can do this standing up, you can face the patient and you can do what we call a hand in palm. So you ask patient to put hand on hand and now ask them to stand on any leg. So say for example, he's standing on the right leg. So if the patient had a positive or a weak abductor on the right side, he will start putting more pressure on my left hand. So you will, in order to compensate or falling off, in order to stop the pelvis dipping, I will feel more pressure on my right hand, and that will be a positive test. Same way, if we stand on the opposite side, just switch the leg. Now we are testing the left side. So if I feel more pressure on my left hand, then it's a positive test. If the pressure is equal and the patient, you can visibly see ASIS is up, then that is a negative test. The second way in which you can do the Stendelberg test is from the front, and it is also an accepted method of testing if you are appearing in FRCS. So you get on your knees and then put hands on ASIS and then ask patient to stand on one leg. So now I can see my left thumb is gone up. So that means this is a negative test. But you need to wait for 30 seconds. Now because we are making a video, I will not wait for 30 seconds. Same way you can switch the leg and test the other side. Now if you're appearing in an exam in India, for some reason examiners, they prefer to look the patients from the back, and you do the same thing, asking patient to stand on one leg, and then you will comment on two things, whether the dimple of Venus, the PSIS is going down or up, and also look at the gluteal fold. And some examiner would not be happy if you don't comment on the gluteal fold. So comment on the gluteal fold that it is going up if in normal, or it is dipping down in an abnormal test. So this is how you would assess a gait, and my advice is do gait first before moving on to our next part, and that would be looking or inspection. Once you have taken a thorough history, then you move on to the examination. And for an examination to be done properly, you need to have patient adequately exposed. So if you're examining anybody's hip, then the patient should be in the underwear so that you can see the top and you have got full access to the leg as well. So that is the bare minimum that I would recommend. So once your patient is appropriately exposed, then you need to examine the hip first standing up, then sitting, and then lying down. But let's start first thing, examination standing up. So when you examine the patient standing up, you look the patient from the front. So when I'm looking at the patient from the front, I'm looking, first thing is the coronal balance, whether there is obvious abnormality in the coronal balance, or the patient has got an abnormal coronal balance. So whether the head is in the center, whether the shoulders are at the same level or not. If there is any obvious deformity or obvious abnormality in the coronal balance, say for example one shoulder is up and one shoulder is down, that could be due to compensatory or a scoliotic deformity of the spine, which may be related to the lower limb. So once you are happy and you have assessed the coronal balance, then the first thing I look is the attitude. What is the generalized attitude of the patient's lower limb? At this point of time, we are focusing on the hip. So we look at the attitude of the hip, attitude of the knee, attitude of the ankle, and this will tell us any obvious deformity or any obvious compensatory mechanism. So for example, if I want to demonstrate, if I stand in front of him, say for example, if my left leg is short. So if the left leg is short, then in order to compensate for this shortness, there are a few things patient can do. One is the patient can bring down the ASIS down, so can tilt the pelvis so that effectively we gain some length. If that is sufficient, that's okay. Otherwise, you can also have an equinus deformity of the feet. That is also a compensatory mechanism. So you will have the equinus of the ankle first, and then you will have dipping of the pelvis. You can also extend the hip, and if this is not sufficient, the opposite limb can also be, or knee or hip can be bent in order to compensate. So if you focus the attitude, this will tell you few things about what deformity it is, and if at all the patient is trying to compensate or not. Now once you have looked at the attitude and commented upon the attitude of the patient, then you look at the skin. Now when you're looking at the skin, of course you're looking at all the things that we look at the skin, which we learned in the medical school, such as scar, any sinus, any swelling, any dilated veins, any obvious bony prominence, any redness or fullness, any ulcers or any obvious pulsations. So these are the basic things that you will look, and these are also relevant for hip as well. Then you look onto the muscle. So from the front, we are looking at mainly quadriceps muscle, because hip, if there is any pathology of the hip, you may have associated wasting of the quadriceps muscles. You can also have wasting sometimes of the leg muscle. So comment on the muscle wasting from the front. Then you look for the bony prominences. So in a thin patient, you should be able to appreciate ASIS and will be able to see whether there is any gross abnormality or whether they are at the same level. Then you can look at the patella. What is the level of the patella? Where are the patella facing? And also over the medial malleolus lower down. So after inspection from the front, we inspect the patient from the side, and at this point of time, we are assessing at the sagittal balance. So I am looking whether the head is in the center or not. So if the head is going forward, that is a positive sagittal balance. If it is going backwards, that is a negative sagittal balance. So here the balance looks reasonably okay, maybe a touch of positive sagittal balance. Now you also look at the deformity or any kyphosis. So here Gopal has got slightly more kyphosis than normal people. You also look at any exaggerated lumbar lodosus. So if somebody has got a flexion deformity of the hip, they can sometimes have exaggerated lumbar lodosus in order to compensate. Looking from the side, then you comment on the skin again, and again skin, the same headings, I don't want to repeat it again. If you find any abnormality in the skin, if there's any scar or not, then you comment upon the muscle wasting. So muscle that we see from the side, you can see gluteus as well, so you can appreciate any wasting of the gluteus muscle, you can appreciate any wasting of the quadriceps, especially the vastus lateralis, and any wasting in the leg muscles. In terms of bony prominence, that you need to look from the side. In a thin patient, if you can ask the patient to move the hand first, you can sometimes appreciate iliac crest, but in a fatty patient, it's very hard to appreciate. And from the side, you can look at the tibial tuberosity or maybe lateral malleolus, but the main important thing I would look at is the GT, ilia or ASIS, iliac crest, and in a thin patient, sometimes you will be able to appreciate the greater trochanter. So once you have assessed the patient from the side, you assess the patient from the back. And again, from the back, you are looking at the position of the head, position of the shoulder, position of this dimple of Venus. And once you have assessed this balance, then you look for any obvious skin abnormalities in the heading that we have talked about. You look for any obvious muscle wasting of the hamstring, muscle wasting of the gluteus maximus, or muscle wasting in the calf, that you should comment. Now, in terms of any bony landmarks, you should, when you are assessing, you should also be seeing if there is any scoliotic deformity in the spine, and that can be seen. You need to appreciate the dimple of Venus, whether they are at the same level or one of them is up or one of them is down. Books talk about gluteal or ischial tuberosity, but it's very hard to appreciate ischial tuberosity. From the side, sometimes you can see where the trochanters are, and lower down you can see, you should be able to see the gluteal fold. On this occasion, just to maintain his decency, I'm not showing you the gluteal fold, but the gluteal fold should be seen, level of popliteal crease, and then level of heel in the feet you should see from the back. So once you have inspected the patient standing up, you must ask the patient to sit down before the patient lies down. And that is predominantly because any compensatory mechanism that has been happening, you eliminate that. So if there was discrepancy in the level of PSIS or this dimple of Venus due to a limb-length discrepancy or due to any adduction and abduction deformity, you eliminate that. If there was any scoliotic deformity which was a compensatory due to a fixed adduction or abduction deformity or any limb-length discrepancy, then you take away that. So if the deformity corrects, say for example, if Gopal had a scoliosis and now the scoliosis is correcting, and that means that there is nothing wrong here, it was all a compensatory due to a hip pathology or pathology in the lower limb. Similarly, if the PSIS or the dimple of Venus, they were at a different level, now as soon as the patient sits down, they become at the same level, then again that tells you that it was a compensatory mechanism. Once you have examined the patient sitting up, then you lie down the patient preferably on a hard couch, because that makes your examination much easier. On this occasion, we don't have access to a very hard couch, but it is reasonably hard. First thing you comment is a comment of the attitude. So we have deliberately created some deformity here. So you comment from the top. So if I have to comment here on attitude, attitude is nothing but it's a position in which body is at ease or comfort. So I would say that looking at the attitude of the right side, both hip and knee are slightly flexed. The leg or the feet is slightly externally rotated. Now, attitude can be quite a giveaway in different pathologies. So I would like to talk about few attitude which are commonly seen in our day-to-day practices. So on this occasion, if you can see, the hip is flexed, it is also adducted, and it is internally rotated. Now this is an extremely common deformity that you will see in posterior dislocation of the hip. So now the next deformity that is also extremely common is flexion of the hip, abduction of the hip, and slightly external rotation. And this is seen in patient with synovitis of the hip, or if they have any collection, because that is the position of the comfort in which the joint is able to accumulate more fluid. So this is seen in synovitis or infection. Now the third deformity that we usually see in our emergency department is patient comes with a painful hip with the leg completely externally rotated. Now, the two common pathologies that are seen across the hip is one is an intracapsular fracture and the second is an extracapsular fracture. And you can subtly differentiate both of them. So, in extracapsular fracture, the lateral border of the feet will be completely touching the floor or the bed. And this is because the fracture is outside the capsule. So, due to gravity and the short external rotators and due to the weight of the limb, this is in a lot of external rotation and there will be shortening. In intracapsular fracture, the feet will be slightly more externally rotated than the other side, but most times it will not be touching the bed, and that is because the capsule is still attached on some part of the bone. So this is a subtle difference. So attitude is extremely important. So do mention about attitude of the limb as soon as the patient is lying down. Now once you have commented upon the attitude, just to make things a bit more clearly, I have marked it some of the bony prominences, but usually you will mark it when you are palpating this bony prominences in the next part of the examination, that is palpation or feel part of it. But again you will comment upon the level of ASIS, whether they are the same level or one of them is higher or lower, level of the patella, whether are the same level, which direction they are facing, whether they are more external rotated or more internally rotated, and the level of medial malleolus looking from the front. Now when you are looking from the side, again you want to see whether there is any exaggerated lumbar lodosus which is seen in flexion deformity of the hip, and you again reinforce your findings about any deformity at the hip or at the knee. Now once you have commented upon the patient lying down from front and the side, then the next section is palpation. Now in palpation you need to palpate the different areas for tenderness like hip joint, the GT or the ischial tuberosity. Now the first thing that I would like to show you is how to identify these bony landmarks so that you can palpate in the right area. So let's start with ASIS first. Now examiner may ask you, how do you palpate the ASIS? Now to examine or to palpate the ASIS, there are two ways. I think the way I find it easier is you come in the center and just go in the line of the inguinal canal, go up, go up, go up, go up, go up, and the first bony prominence that you will hit here is your anterior superior iliac spine. So start in the midline, go along the inguinal ligament. The first bony prominence that you feel is your ASIS. Now the second uncommon way is follow the iliac crest, keep climbing on the iliac crest, and then as soon as once you have reached the end and then you feel a dip, that is the start of the ASIS. So this is how you feel the ASIS. So once you feel it, mark it so that you can comment upon it during your examination. Now the second bony prominence that you need to feel is pubic symphysis and pubic tubercle. Now pubic symphysis is extremely simple. I can't show it just to maintain his privacy, but stay in the middle, and in the midline you will feel the pubic symphysis. On either side, as you move on the side here and move on the side here, you will feel a bony prominences, and that is where your pubic tubercle is, and you will mark your pubic tubercle there. Now the third important bony landmark that you need to identify is the greater trochanter, because sometimes you can have pain across it in trochanteric bursitis, or you can have irregularity over the GT. So how do you palpate the greater trochanter? So again there are two techniques. The common is you bend the knee slightly and then move across the lateral side across the shaft, and then as soon as you reach in this region of GT, you will feel a bony prominence and then you will feel a dip. And as soon as you feel a dip here, that is where you mark as the apex of your GT. Now the second option is to start from the iliac crest and then keep moving down till you feel the first bony prominence. And both of them will lead to your apex or the tip of the GT. So the last bony prominence that you feel across the hip, and it's extremely important, is the ischial tuberosity. Now if you notice, this is the gluteal bulk. Now if you feel in the center of the gluteal bulk, you will feel only one bony prominence, and I can feel it here, and this bony prominence is ischial tuberosity. So you can start from gluteal fold and move up as soon as you feel the bony prominence, that is your ischial tuberosity, and mark it because you will require it later. So once you have, I have shown you how to do the marking. Now the first thing when you do in palpation is palpate and look for any raise in local temperature in Scarpa's triangle. Now you should be knowing the anatomy of Scarpa's triangle because that is an extremely common question. The first thing you will say, I will measure the temperature in the Scarpa triangle. The examiner will ask you the boundaries. So you should be aware of what is Scarpa triangle and what are the boundaries. Now the second thing where people fumble or get confused is where to look for tenderness for the hip joint. So the examiner will ask you, how do you reach your hip joint? Now you can see that we have marked ASIS, we have marked pubic symphysis. Just to maintain his privacy, I have marked the pubic symphysis here. Now you need to understand and know the difference between what is mid-inguinal point and midpoint of inguinal ligament. So this is again a very common question that the examiner will ask. What is difference between mid-inguinal point and midpoint of inguinal ligament? Now to feel for the hip joint, you need to feel and find the mid-inguinal point. So mid-inguinal point is nothing but you feel the pubic symphysis, you feel the ASIS, and the center halfway between is the mid-inguinal point. What is mid point of inguinal ligament? Now I showed you how to feel the just lateral here is the pubic tubercle. So mid-inguinal or midpoint of inguinal ligament is from ASIS to pubic tubercle, feel the half. So where is your hip joint? Your hip joint is, you feel for mid-inguinal point, that is halfway between pubic symphysis and ASIS, and then 1 centimeter below and 1 centimeter lateral. So if this is, you feel for any tenderness of the hip joint. Now the second area that you need to feel for any pain, tenderness is the GT. So I have showed you how to feel the GT. So feel for any thickening, any broadening, or any irregularity across the GT. So that may be giveaway of trochanteric bursitis or any old fracture in that region. So you also need to palpate the posterior hip joint line tenderness. Now I didn't show you how to mark the PSIS. It's very easy. Dimple of Venus just made a round. This is the tip of the GT. So you draw a line and divide it into 1/3 and 2/3 here. And at the junction, that is where you feel for posterior joint line tenderness. In the same position, since you have access to ischial tuberosity, you can feel for tenderness across the ischial tuberosity as well, because hamstring tendons, they origin, and you can sometimes have a pain in the hamstring origin as well. So once you have felt tenderness in this area, in the bony prominences, I think one important thing that is also part of palpation is what we call as a distal Bryan's triangle. So distal Bryan's triangle is an extremely important part of palpation, and that can give you some idea about any shortening that is happening in the supratrochanteric region. So what is distal Bryan's triangle? So distal Bryan's triangle is nothing but it's replication of Bryan's triangle with your digits. So when you do that, your thumb is over the ASIS, your middle finger is over the tip of the trochanter which we have marked, and index finger will be in line with the ASIS and parallel to in line with the GT. So this is how you make a distal Bryan's triangle, and you will palpate the both sides and will compare, and that will give you a rough idea whether if there is any shortening so in supratrochanteric region or not. So one important sign that examiners are quite fond of in India is which we call is a vascular sign of Narad, and that is also a part of your palpation or feel part, and I have shown you how to feel the hip joint anteriorly. So when you go in the mid inguinal point and go 1 centimeter below and lateral, that is where you feel the femoral pulse as well. So if you are feeling the femoral pulse on both the sides, and if they are symmetrical and they are bounding and normal, that is a negative test. So again, at this point of time, students, they get confused, what is a positive test? So a Narath's vascular sign of Narath is positive if you feel for the pulse, and if it is feeble or absent, that can be suggestive of a dislocated hip or hip which is not in its position. So a positive sign is when the pulse is feeble or absent in comparison to the other side. So when you are describing this particular sign, say for example, if the pulse on this side was, when you feel for it, it was not palpable. So you say that on my examination, this pulse on the right side is not palpable. Don't say that pulse is absent, because some examiner in India, they get offended by this. So say the pulse is palpable or not palpable rather than present or absent. So last few things that I would like to cover as part of palpation is transmitted movements. So if I move the hip lower down and I want to put my hand over the GT, see if the GT moves or not. If the transmitted movements are not there, say if I move it and the GT is not moving, that may suggest a fracture. Also, if you are moving the hip, and if you feel any globular mass or any big swelling in the back, and when you're moving the hip and the globular mass is also moving, then that tells that this is more likely to be femoral head or a femoral prosthesis if the patient had a replacement. So once you have finished with your palpation, I think the next important bit where the students, especially postgraduate students who are appearing in the exam, get more perplexed or confused is deformity. So a deformity is a position in which joint is held, where movement in the same plane is possible, but the movement in the opposite plane is not possible. So to make it clear, now deformity can happen in 3 planes. It can happen in sagittal plane, it can happen in coronal plane, it can happen in axial plane. Now in sagittal plane, now you have got fixed flexion deformity or fixed extension deformity. Now fixed extension deformity is extremely rare. In coronal plane, you have fixed abduction deformity, you have got fixed adduction deformity. In axial plane, you have got fixed external rotation or fixed internal rotation deformity. Now, when I talk about the definition, when I said the movement in the same plane can happen, but the opposite movement cannot happen. So it's extremely important that if you say the patient has got fixed flexion deformity of, say for example, 20 degrees, and then the examiner probes and asks you, so how much extension is present? So you have to say there is no extension present. So if you say any amount of extension, then that is a wrong answer. So if you have got a flexion deformity, then extension cannot happen. If you have got a fixed extension deformity, then there is no possible flexion. If you have got an abduction deformity, then adduction is not possible. Or if you have got fixed adduction, abduction is not possible. So vice versa. Now we will pick one by one. So let's start with sagittal deformity, and then I will demonstrate you in a patient how to measure a fixed flexion deformity in a patient. The first deformity that we will talk about is what we call is a flexion deformity of the hip. So as I said before, if you have got flexion deformity, then you will have no extension. So the common test that we talk about is what we call is a Thomas hip flexion test. Now this test is one of the favorite topics of all examiners irrespective of country. So whether you are appearing in FRCS, whether you are appearing in MS, if you do this test incorrect, there is a very good chance that you will repeat the exam again. So I'll tell you how to do this Thomas test properly. So first and foremost is, for exam, patient has to lie down supine. You should have a patient preferably on the hard couch, and you should be having access of the whole patient so that you can see the lumbar lordosis and you can examine the leg as well. So I'm just trying to recreate, say for example, the patient had a flexion deformity of this much. So say for example, patient has this attitude of hip flexion of around 30 degree. Now how to do this test? Now to do this test, the first thing that we want to make sure, I will tell you later on, is that this lumbar lordosis is extremely important. If this patient had this much deformity but he was keeping his leg straight, what you will notice is the patient will have hyperlordosis. So patient will have increased lordosis of his spine in order to mask this deformity. So for this, on this occasion, we will presume that this is the abnormal side. The right side is the abnormal side. So I am going to bend the left knee till the lumbar lordosis is obliterated, so that it is flat and I am not able to slide my hand underneath it, or I am not able to see it across. And then you ask the patient to hold the leg. And in this position, say for example, the patient leg becomes like this. Now, this is not your fixed flexion deformity. So I would like to reinforce, so what is fixed flexion deformity? Once you have got this attitude, then you just passively extend. And inevitably, most times you will see that you will be able to correct it slightly. Now, whatever this residual deformity now is left, this is the flexion deformity of your right hip. Now, there are a few other things which are equally important. Once you have assessed the flexion deformity of the hip, then you need to check how much flexion the patient can do. So first you ask the patient to actively flex the knee. So if he can actively flex the knee like this, so this is his active free flexion range. And say for example, after this he is not able to flex, then we need to see whether there is any further passive flexion range and making sure that the pelvis is not moving. So hand on ASIS. So this will be his passive flexion range. Now this is how you assess or do a Thomas test properly, and also you have to assess whether this range of motion, whether it is painful or pain-free. Now life is not that simple, and examiners, they do like or love to put the students under some stress. So the Thomas test, they will put you some questions, and one of the common questions they will ask is that if the deformity is little, say for example 10 degrees, how could you be sure whether you're obliterating it or whether the patient has got 10 degrees of fixed flexion deformity? And that is a very valid question, because in real life, if somebody has got FFD of just 10 degrees, you may struggle to identify it. So how would you do it? So the only way, or the way I find is much easy, is I would say I would lie the patient prone, and if the patient has got a flexion deformity, there will be absent extension. So on this occasion, let's imagine that this is the side in which we are suspecting that patient has got a mild FFD of say 5-10 degrees. So if you lie the patient prone, you will see that hip is flexed, and when you try to extend the hip, there will be no extension. So this is your answer, that I will lie the patient prone in order to confirm a mild FFD. Now the second trick question that is usually asked in examiner or exam is, the examiner will say, if this is the attitude of the limb, how can you be sure that this FFD of the hip is not because of the FFD of the knee? And that is also a very valid question, because if the knee has got a fixed flexion deformity of say 30 degree, if the patient is lying on the couch, it will manifest as an FFD of the hip as well when you're looking at it. So the easiest way is to take the patient to the edge of the bed and let the knee hang, and I'll show you how. So if you see, the patient knee is now hanging. Now, so knee is out of equation. So if the FFD was due to knee flexion, then, or knee FFD was due to FFD of the knee and the hip was flexed, once you take the knee out, then you eliminate it. Now whatever patient is now reflecting is purely because of the hip and not to the knee. So your answer is I will take the patient to the edge of the table, I will hang the knee, and if there is still FFD, then it is not due to knee but it is due to hip. Now the other way is to check the patient in prone, and I will talk about it when we will talk about Stendelberg test in case of bilateral FFDs. Now the other scenario that the examiner may ask is what would you do if both the hips have got fixed flexion deformity? Now if the patient has got bilateral deformity, then there are two ways you can do it. If you are appearing in FRCS, then the easiest way you can say is that you will bend both the knees until you obliterate the lumbar lodosus as you would do in the Thomas hip flexion test, and then ask the patient to extend one hip, check the FFD, and then to the other hip. This is probably the easiest way, but some examiners in India, they feel extremely nervous about it and they feel that this is not the right way. But I tell you, this is perfectly fine if you have got bilateral cases. Now, if the other option is, which Indian examiners they love, is if you have got bilateral pathology or FFD, then they would like you to talk about Stendelberg's prone test, and I'll show you what it means. So as the test mentioned that Stendelberg's prone test, the patient has to be prone, and you bring the patient to the edge of the bed in such a way that both thighs and the legs are hanging down. Now this is an extremely good test in case of bilateral pathologies, or if there is flexion deformity of hip as well as simultaneous flexion deformity of the knee. So with this test you can assess everything, and I'll show you how. So for this test, put your hand on the back where your lumbar lodosus is, and then slowly start extending it. So if the patient has got fixed flexion deformity, as soon as you start to extend it, your spine or the pelvis will start to move, your hand will start to move, and that is your flexion deformity. Same way, in this same position, if the patient has got flexion deformity of the knee, when you try to extend, this will not extend straight and it will remain like this. So you can assess the flexion deformity of the hip and flexion deformity of the knee at the same time. Similarly, on this side, if I'll extend, on this occasion, see my hand is not moving because this patient has got no flexion deformity. So this is your Stendelberg's prone test. Now opposite of fixed flexion deformity is a fixed extension deformity. And to be honest, it's extremely rare, and in my orthopedic career I have never seen a case of extension deformity. But as the definition implies, you will have extension but then you will have no flexion. So opposite movement is completely absent. So in fixed extension deformity, if the patient, say for example left hip had an extension deformity, the hip will be in this particular position, it will be slightly extended. It is uncommon, and when you try to flex, this will not be possible. So it is an uncommon finding, but it can be seen on rare occasion. So opposite of fixed flexion deformity is fixed extension deformity. Now let's move on to coronal plane deformities. So let's now talk about coronal plane deformity. Now coronal plane deformity can be quite mind-boggling, and especially if you are preparing for exam, it can be quite confusing, and even senior clinicians sometimes find it difficult to understand. So I'll try to simplify it so that you don't have any confusion when you're reading it or when you are examining a patient in the exam or in the clinic. So here I have just made a diagram where I have shown that the left side has got a fixed abduction deformity. So we are talking about fixed abduction deformity first. So the left leg is abduction deformity. As I said, will have abduction but will have no adduction. If you say in an abduction deformity that there is 10 degrees of adduction, that means pay your fees again and you're reappearing in the exam. So opposite movement is completely absent. Now imagine I have got a fixed abduction deformity of my left leg as shown in the diagram. Now there is no way I can walk with my leg in this position. So what I would do is, in order to walk, I have to have my leg parallel to the other leg. So I will, to correct the deformity, I will get the leg towards the center in the midline and I will have to dip my pelvis. And hence, if you have got a fixed abduction deformity, in order to get leg parallel to the other side, the pelvis or the ASIS will dip on the same side. And I have shown it in the diagram as well. So nobody can walk like this. So what they do is they try to get leg parallel, and during that process your ASIs will go down. So this is the first point. If you have got a fixed abduction deformity, then your anterior superior iliac spine on the affected side will be lower. Now as you are getting the ASIS down, definitely it will lead to the leg length being longer, or there will be an apparent lengthening. So if you look at the diagram, I am getting the ASIS down, so what it will effectively do is there will be apparent lengthening on the affected side. Now of course if you have tilted the pelvis, it will have effect on your spine as well. So you will have a compensatory scoliosis. So if Varun can show me, if I am standing like this and if I have got a fixed abduction deformity and I am bringing the ASIs down, so I am becoming like this, but can I walk like this? I cannot walk like this. So what I will do, I will compensate, and to bring the head in the center, my spine will curve towards the affected side. So convexity of the spine will be towards the affected side. So if I reinforce it again, if I cannot walk like this, I will dip my pelvis, but to bring the head center, I will have a scoliosis in the spine, and this convexity will be on the same side. Now if you have got any amount of limb length discrepancy, say for example 1 centimeter, we say that there is 10 degree of deformity. So if somebody has got a shortening of say 1 centimeter, then there will be around 10 degrees of abduction deformity. Now the most important thing which I have marked here is, when you examine the patient in the exams, you will have few scenarios, and in abduction deformity, your true shortening is greater than apparent shortening. So if somebody has got a shortening, what happens is the apparent shortening will be much less, because as I said, in abduction deformity the pelvis will go down, and as the pelvis will go down, there will be apparent lengthening. This is the compensatory mechanism. So if somebody has got say true shortening of around 3 centimeter, if there is an abduction deformity, the abduction deformity will be to compensate. So it will be say for example 1 centimeter, then that means out of 3 centimeters, 2 centimeter has been compensated by tilting of the pelvis, and because of the tilting there is apparent lengthening, hence your apparent shortening will be lesser. So to summarize, in abduction deformity you will have ASIS lower, there will be apparent lengthening, and this is the compensatory mechanism. Convexity of the spine will be towards the same side, and for 1 centimeter of limb length discrepancy there will be 10 degree of deformity. So in this particular scenario, if there is true shortening of 3 centimeters but there is apparent shortening of 1 centimeters, that means 2 centimeters has been compensated. So you will have roughly 20 degree of abduction deformity in this patient. So now opposite of abduction deformity is a fixed adduction deformity. So I would reinforce again, if patient has got an adduction deformity and to the examiner if you say there is abduction of 10 degrees or 20 degrees, then you have failed your exam. So opposite movement is absent, and I'm repeating it again and again. Now again, I have reproduced this deformity, adduction deformity in this diagram. So we will presume that left side has got an adduction deformity. Now again, if I have an adduction deformity like this, say for example 20-30 degrees, there is no way I will be able to walk like this. In order to walk and mobilize, I will have to get this leg parallel, and if I have to get the leg parallel, what I will do is I will lift the ASIS towards the higher side, and this is what I have shown here. ASIS on this will be on the upper side. So as you have got ASIS up, so now what will happen is, if I am lifting, because of the deformity, to get it parallel, I am putting my ASIS up. What it is doing is it's lifting my left leg up, and in comparison to the right leg there is now an apparent shortening. So you will have an apparent shortening in adduction deformity. Now where will be the convexity? Again, if Varun can show me, just on the top. So I have got an adduction deformity, I am lifting my ASIS up, and what this is doing is I am tilting to the opposite side. Can I walk like this? No. So to bring the head up, I will bring my head in the center, and if you see, this convexity is now this way and this is on the opposite side. So convexity will be on opposite side. And again, for each centimeter of limb length discrepancy, there will be 10 degrees of deformity. So if there is a lengthening of 1 centimeter, then there will be associated 10 degrees of fixed adduction deformity. So the last thing that I want you to focus is here. If when you're examining a patient, then you do measure true shortening and apparent shortening if there is. So if you see there is true shortening in this scenario, in adduction deformity will be actually less than the apparent shortening. So the true shortening is less apparent shortening than apparent shortening, and that is because if you see here, because the pelvis is lifted up, there is apparent shortening. So the shortening is exaggerated. So say for example, if there is true shortening of 1 centimeter and there is apparent shortening of around 3 centimeters, this will be a scenario if you have got a fixed adduction deformity. Now there is only 1 centimeter of true shortening, but when you measuring apparent shortening, there is 3 centimeter shortening. So difference is around 2 centimeters. So that means the patient has got roughly 20 degree of adduction deformity. To summarize again, in adduction deformity we'll have ASIS up, there will be apparent shortening, convexity will be on the opposite side, and true shortening will be less than apparent shortening. So now let's see it in a patient, that if somebody has got abnormality in the coronal plane, whether it's a fixed abduction deformity or adduction deformity, how to clinically measure that deformity. Let's talk about the fixed abduction deformity first. Now say for example, the patient has got an abduction deformity on the right side. So if the patient has got an abduction deformity, and to keep the leg parallel to each other in the position they want to mobilize, the ASIS on the right side will be lower than the left side. Now he is not a patient, he doesn't have any deformity, but just to reproduce it, I have asked him to tilt. So you can't see, but ASIS on the right side is lower than the left side, and I can appreciate it that. So in order to assess the deformity, what you need to do is that you need to bring the ASIS at the same level. So in abduction deformity, to bring ASIS to the same level, you need to abduct the affected leg in order to square it. So in abduction deformity, abduct the leg. So I'll keep abducting the leg, keep abducting the leg, keep abducting the leg, keep abducting the leg till ASIS becomes parallel. Say for example, in this, after doing this much of abduction, my ASIS is now at the same level. Now this is not your abduction deformity. As I said in the flexion deformity as well, that this is not your abduction deformity. Your abduction deformity is that you put your thumb on ASIS and then slowly adduct, and as soon as you move, you see the first movement of, or feel the first movement of ASIS, this residual deformity is your abduction deformity. So draw a midline and measure this angle. Say for example, this is 20 degrees. So like in flexion deformity, once you square it, adduct it slightly so that you see the movement of the ASIS. And as soon as you start feeling that the ASIS is moving and it's going down, that is your residual angle and that is your abduction deformity. Now, same as in flexion deformity, you can ask the patient to abduct to see if there is any further abduction possible. So this will be the free active abduction range, and if the patient can abduct up to this much and then you further abduct, but keep an eye or a hand on ASIS to make sure that the ASIS is not moving. If this much abduction is possible, then this is the free active abduction range. Now this is how you measure your fixed abduction angle. So in fixed abduction, your adduction will be 0. Now opposite of fixed abduction deformity is fixed adduction or adduction deformity. Now it is just opposite of abduction deformity. So again I have reproduced a deformity, and on this occasion I can see that the ASIS on the right side is now up. In abduction it was lower, now it is up. And if you look at the heel here, because of the deformity, there is apparent shortening, as I had explained earlier. If you want to measure the adduction deformity, then you have to get the ASIS to the same level, or what we call is a squaring of pelvis. So if you want to square the pelvis in adduction deformity, you need to adduct the leg. So as you adduct the leg, say for example, if this much adduction is causing the pelvis to square, you stop here, and then as in abduction deformity, you move or abduct the leg slightly, and what you will notice is your ASIS, as soon as it starts to move, you stop. And this deformity, which is parallel, if you measure with this angle, this is your adduction deformity. So it is just opposite. So like in flexion deformity, once your pelvis is square, you just abduct slightly till you move or till you see a movement of the ASIS. So this will be your adduction deformity. Now, what is your free range? Now I have talked about free adduction range and free active adduction range and passive free adduction range or abduction range. Now it doesn't have to be present all the time. Say for example, if this is the deformity, and if I move the leg, or if the patient moves the leg and ASIS moves, then there is this is the only amount of adduction he can have. So if he can have this much, then this is the free range, and at this point of time, and this is the active range if the patient is doing himself and the ASIS has not moved. However, after the active range, if I move passively and the ASIS moves, then the passive range is, there is no difference between active and passive range. But there are occasions when you can passively adduct more, and only after certain adduction your ASIS will move, and that will be your free adduction range. And again, you have to see whether this is pain-free or painful. So this is how you measure it on a patient. So when you are moving your leg or adducting the leg to measure the deformity, there are only two ways you can do it, because once you adduct, either you have option of putting the leg on the opposite leg till your pelvis is squared, depending upon how much adduction deformity is there, or the other option will be, if this is not getting square, you have to put the leg out of the way and then get the pelvis square. These are the only two ways, I think, but you can do either ways. This is much easier, just putting the leg on the top of the other leg. Now there are two other methods which examiner may ask you about in you're talking about coronal plane deformity such as abduction or adduction deformity. One is the Kothari's parallelogram and other is the Chinese line or test. So I will show you on a board and explain it better. But if you see here, for the technique that I showed you previously required your pelvis to be squared. That means ASIS has to be at the same level. When you are using a Kothari's parallelogram, you don't need your ASIS to be the same level. However, your both limb should be parallel to each other. So that is the only prerequisite. And it is very difficult to explain in a patient. So I will switch on to the board where I'll talk about Kothari's parallelogram and Chinese line or test. So if you see this diagram, this is our ASIS and this is the other ASIS. Now you can see one ASIS is higher than the other ASIS. Now normally we will get or we will reproduce the deformity till both of them are the same level, while in Kothari's parallelogram we don't have to do that. So depending upon which leg is affected, say for example this is fixed abduction deformity, patient of this leg has got fixed abduction deformity, hence ASIS is at the lower level. So what you need to do is you just need to draw a midline going through the umbilicus, and then you draw a line from ASIS at 90 degree to this particular vertical line, and similarly here 90 degree to this particular line. And then you draw a cross line across ASIS. Now this angle which is made, name it alpha angle or whatever angle you want to name it, will be your fixed abduction deformity. Similarly, if say for example this side had an adduction deformity and ASIS was higher, this angle will be adduction deformity. So you can measure it easily. So some examiner may ask it. It's not so important for FRCS, but for MS or any exam which is happening in developing countries, examiner, they love it and they ask it. So the second test, which is called Shine's test or Shine's line, is also important, especially if you are giving exams in developing country. Examiners are very fond of it and they may ask. For FRCS, I have not seen any examiner asking this, so it's an uncommon question. So what is a Shine's test or Shine's line? So this is your ASIS or anterior superior iliac spine, and this represents your greater trochanter. So in a normal patient, if you draw one line connecting this ASIS and the second line connecting the tip of the trochanter, then they will be parallel. So if the line is parallel, that is normal finding. Now, because we are assessing coronal plane deformity, now in coronal plane deformity, we presume this is the abnormal side. And here you can see the ASIS is lower than this side. So this is representation of an abduction deformity, as we have discussed before. So what will happen in abduction deformity is, if you draw a line, now this line of course will remain parallel because this is not going anywhere. However, if you connect these two, then it is eventually going to converge on the affected side, and if they converge, this is your abduction deformity. Now the third scenario will be, if this is the abnormal side, the ASIS has gone up. Now we have discussed this before, that ASIS goes up in adduction deformity, as I had shown you before. So in adduction deformity, ASIS has gone up. So if you draw this line, of course this line will remain parallel again. But if you connect these two lines, now on this occasion, you will see that it is diverging on the abnormal side and it will converge on the unaffected side. So depending upon which side it is converging or diverging, you can easily tell which deformity it is. So if it is converging on the abnormal side, this is abduction. If it is diverging, then it is adduction deformity. So now I hope you have understood abduction and adduction deformity. Now the third component is a rotational deformity, which is deformity in the axial plane. Now this is not so difficult to understand. Now one question that examiner may ask, as you know, that in normal patients the movement of extension or movement of rotation is less in extension and it is more in flexion. So they may ask you why is that, and the simple answer is because capsule is more relaxed when you flex the hip, that's why you have more rotation. Now let me show you how to assess a rotational deformity of a lower limb. Now rotational deformity can be either an external rotation deformity or an internal rotation deformity. And as we have been saying this and reinforcing it again and again, if patient has got an external rotation deformity, then internal rotation is 0. Vice versa, if patient has got an internal rotation deformity, then external rotation deformity is 0. Now this is a normal patient, but I have deliberately reproduced some deformity on the right side. Now if you notice, this right side is rotated much more. There is more external rotation, and that is also obvious by the, if you look at the patella is not facing the ceiling, it is facing more laterally. So if I move, if I am moving inside, if I am trying to do internal rotation, then once it has reached its deformity, there will be no further internal rotation movement possible. So say for example, if it is lying like this, but when I do this, it can come up to here, but after this there is no movement, then this angle with this vertical line is your deformity. And again, as I said before, internal rotation will be absent, but when you try to external rotate, you may have some external rotation, like we had some flexion or some abduction or adduction. Now opposite of it will be, if the, say for example, patient had feet like this and I am trying to external rotate, and after this I am not able to external rotate. So this angle with this vertical angle is your internal rotation deformity, and in internal rotation, external rotation will be 0. How to measure external or internal rotation deformity? It is very easy. Grab the legs above the malleolus so that you lock the knee, so that any movement now happening is happening at the hip joint, not at the knee joint. So just give you an example, just for a demonstration. If you can see, this is normal side, is internally rotating this much, and on this side, after this I am not able to get past this, then this is the amount of external rotation deformity. So patient can further externally rotate, but there will be no further internal rotation movement. Now how to measure the angle? Now it's, as I said, you draw one line with this and one line vertical, or the other option is, if you have two pens, if Varun can show it, then if you put one pen vertical facing the ceiling here and the other pen facing, if this is the external rotation in the direction of the patella, which will be matching the direction of the foot. So the angle this makes is the amount of external rotation deformity. Similarly, the patient may have an internal rotation deformity, and then I'm trying to external rotate, patient is not able to do so. And you can do the same thing comparing in the, you have to measure in the flexion as well when the hip is flexed. One common question that the examiner may ask when you are doing or assessing this rotation is, what is axis deviation? Now, if you see and examine a normal hip, if I try to flex it, you can easily take this hip towards the opposite shoulder. However, if somebody has got SCAFI or slipped capital femoral epiphysis, then when you try to flex the hip, then your hip goes into external rotation, and this is your axis deviation. So the second thing that you should also know is what is differential rotation. Now this is seen in Perthes and Sufi both. What happens is, if you see, as I said, the internal rotation is restricted and there will be increased external rotation. So the external rotation on the affected site will be slightly more in comparison to the non-affected site, and this is called as differential rotation. The third thing that you should also know is what is a sectoral sign. So this is seen in cases of avascular necrosis, where you will see differential rotation or difference in rotation when the hip is extended to when hip is flexed. So say for example, if the anterolateral part of the femoral head is involved, if you check the internal rotation here, the internal rotation in extension will be pretty good. However, when you flex the knee and then you internal rotate, there will be a gross restriction, and this is a sectoral sign. Now once you are done with your deformity, then you need to check the movements of the hip, and I'll show you how to check the movements of the hip. Now, movement you would have assessed to large extent when you are assessing the deformity in the three planes, but just to demonstrate you how do you measure these different movements, let's start off with flexion. Now flexion, all the movements should be active as well as passive. So I'm just going to demonstrate passive. One thing that is important is that you have to examine the isolated movement of your hip joint. And you know that even if the patient's hip joint is fused, due to movement of the pelvis, you can still have a lot of movements, and it is quite deceptive. So ASIS is your key, and that will tell us whether the movement is happening at the pelvis or not, because if there is any movement of ASIS, that means that the pelvis is moving. So for flexion, I will keep my hand or thumb on ASIS, and then I will flex it if I am doing passive, and now the ASIS is starting to move. So this is the amount of flexion that the patient has. Normally you can have flexion actively up to 0 to 100, and then passively up to 130 to 100, roughly around 130 degree of flexion. Now extension, you will measure either patient lying prone or patient on its side. So I'll show you when we turn the patient on the side. So to check the extension, again I'm putting my index finger on the ASIS, and then I'm going to slowly extend. Till now my finger is not moving, but now you can see my finger is starting to move. So this is now extension, and normally you have extension of somewhere between 15 to 30 degrees. Now adduction and abduction measurement is very simple. Either you can, if you have got a small patient and you have got a big hand, then you can keep both hands on ASIS, or I prefer just one hand on ASIS, and then for abduction I will just move the leg. Now my ASIS is about to move. So this is my abduction range. If I am doing adduction, again you can go across till now the ASIS is starting to move. So this is your adduction range. Now your abduction is roughly around 45 and your adduction is slightly less, it's usually 20 to 30 degree. Now rotation, I have shown you when I was showing how to check for a rotational deformity. Now I'll get in the way of camera. So this is, you need to check in extension as well as in flexion. So the most people that some point early in the career, they get confused. Now if your foot is going out like this is internal rotation, and if your foot is going inside, then it is external rotation. And you can see internal rotation is much less, even in normal patient, comparison to the external rotation. So this is how you measure your rotations. So whenever you are assessing the movement, it is extremely important that you assess where is the restriction, whether it is in one plane. If it is one plane or in one direction, it is called uniaxial restriction of movement, or if there is decreased movement in all the areas, then it is called as global restriction of movement. There's one term which is also used, which is called differential movement. Now, what is differential movement? If the examiner asks you what is differential movement, then in differential movement, there will be restriction of movement in one direction, and in other direction, the movement will be either normal or there will be compensatory increase in the range of movement. Once you have assessed the movement, then you move on to the next territory, which is called measurements, and again a very, very favorite territory for the examiners. So when you talk about measurements, we talk about apparent measurement and we talk about true measurement. Now the first question that I have seen examiner in India asking is it important to measure apparent measurement? Why can't we just do a true measurement? Now the answer to that is apparent measurement gives you an idea about the compensation. Whenever there is a problem, then apparent measurement will tell you whether there is a compensation, whether there is a complete compensation or an incomplete compensation, and hence it is important. So there are certain prerequisites for apparent measurement, and I will demonstrate you again on a model, but the prerequisites are that the patient has to lie down supine and both limbs should be parallel to each other and parallel to midline. So let me show you how to do apparent leg length measurement. So this is what I mean, that both limbs, they should be parallel to each other and they should be parallel to the midline. We don't really care about the position of ASIS for apparent length. So if this is the position, in this position you cannot, because the legs are not parallel to each other. In this position, the legs are parallel to each other, but they are not parallel to midline. So you have to be parallel to midline and parallel to each other. And once you are in the correct position, then you need to measure from a fixed bony point, and that is usually xiphisternum. Now, in a thin patient, you can use umbilicus, but umbilicus is not a reliable landmark. So I always use xiphisternum. So take a tape and then measure it to the medial malleolus. Now again, examiner may ask you, where do you measure in medial malleolus? Because medial malleolus itself is quite a big area. So if I draw it here, it's a big circle. So if you feel the medial malleolus, there is a sharp edge which is called the crest of the medial malleolus. So you measure up to the crest of the medial malleolus on the right side and then the left side, and then you do the recording of your apparent measurement. So this is how you do apparent leg length measurement. So once you have done your apparent leg length measurement, then you move on to the true leg length measurement. Now as with apparent leg length measurement, you have some criteria or fixed criteria for or prerequisites for true leg length measurement, and they are: firstly, your pelvis has to be square. That means your ASIS should be at the same level. So if I draw a line through the center, and if you draw a line through the ASIS, they should be 90 degree to each other. And this is what we call as squaring of pelvis. So if somebody asks you what is squaring of pelvis, it is when we draw a horizontal line through the ASIS, if it cuts at 90 degree to the midline, mid-axis line, that is when the pelvis is square. So first criteria is that you have to have pelvis square, and the second criteria is that both the limb should be in identical position. If for any reason you are unable to get any of these prerequisites, and if an examiner asks you to tell how much is your true leg length measurements, then you just have to say, I'm sorry sir, I have not been able to get the leg in identical position, and I have not been able to square the pelvis, hence I am unable to give that reading to you. So for measurement, of course, your patient has to lie supine. If you are measuring it in a supine position, you can measure it in the standing position as well, and I will show you how to measure the limb length or limb length discrepancy or true measurement standing up. But let's first talk about lying down. So first thing you want is to square the pelvis. Now, as I said, in abduction deformity you need to abduct, in adduction deformity you need to adduct. So follow those principles and then square the pelvis. And as I said, the second prerequisite is that limb has to be in identical position. For example, if this is the site of abnormality and this is the position of the limb, and we cannot correct this, then we have to recreate the deformity on the opposite side so that both the legs are in identical position. Then only you can do the measurement. And once you have got the leg in the identical position, then you can measure it from any fixed bony point. You can measure it from xiphisternum, or you can measure it from ASIS up to the medial malleus. But the key is to get the leg in identical position. Now, if the commonest deformity that you will see is flexion deformity. Now, flexion deformity is easy to recreate flexion on the opposite side. In abduction deformity, if this is the abduction deformity, then to square the pelvis, the best thing will be to recreate the deformity on the other side as well. Adduction deformity is slightly tricky. So if this leg has got adduction deformity, to square the pelvis, I need to adduct, then I will measure it from ASIS down to the crest of the medial malleolus, and once I have measured it, I will put this leg down and then I will reproduce the deformity on the opposite side, and then I will take the measurements from the opposite side and record my readings. So this is how you do a true leg length measurement. So the second easiest option, which a lot of physiotherapists use in order to check the true leg length discrepancy, is standing up. And say for example, if they have to give a shoe raise, then this is how they do it. So say for example, on this right side he had a shortening of say around 1 centimeter, and due to this shortening he has got an abduction deformity. Now in abduction deformity, you know the ASIS will be lower. To get the ASIS up, all I will do is I will take roughly a centimeter block and I will put it under his leg. And as soon as, say for example, if this shoe is roughly a centimeter, if I ask him to wear it, I don't have a block, what it will do is it will bring the pelvis, or sorry, ASIS to the same level. So the amount of the thickness that goes underneath the heel in order to bring the ASIS at the same level is the amount of true shortening. On the contrary, if there was a lengthening on this side, say for example we did a total hip replacement on his left side and now he has got a lengthening on this side, and due to this lengthening, how do we identify how much lengthening it is? So what we will do is, on this occasion, we will put the block not on the same side but on the unaffected side, so as to give him the shoe raise and bring the ASIS to the same level. And again, the amount of thickness of the block that you put underneath is amount of lengthening. So this is how you can measure the true shortening or true lengthening with block method while standing up. Now, once you have done your measurements, then you will come across usually these three scenarios. So true shortening stands for, I have said TS, apparent shortening is AS. So one of these three things will happen. Either true shortening will be equal to apparent shortening. So apparent shortening and true shortening, when they are same, that tells us that there is no compensation. So nothing has happened. On the other hand, and I've explained this in the coronal plane deformity as well, if the true shortening is greater than apparent shortening. So say for example, if the true shortening is 3 centimeters, but apparent shortening is 1 centimeter, and this will happen only usually in the fixed abduction deformity. So what is happening is ASIS is coming down, and hence the apparent shortening is less. But when you square the pelvis, as ASIS goes up, the shortening becomes 3 centimeter. So that means if this is 3 centimeters and this is 1 centimeter, that means that there is compensation of around 2 centimeter, which will be equivalent to around roughly 20 degree of abduction deformity. The third scenario will be where true shortening is less than apparent shortening. So say for example, if true shortening is 1 centimeter but apparent shortening is 3 centimeter, and this usually will happen if in adduction deformity you lift the ASIS and the apparent shortening will be exaggerated. So if it is 1 centimeter of true shortening, but when you are measuring it apparent, it is coming 3 centimeters, that means the 2 centimeter, the difference will be 2 centimeter. That is because of upriding of ASIS due to fixed adduction deformity. And as we said, if there is LLD of 1 centimeter, that will correspond to roughly 10 degrees. You will have roughly 20 degrees of fixed adduction deformity. So once you have done these measurements, then you want to identify where is your shortening. So a rough assessment or a good screening test is what we call is a Gallium test, in which we bend the knee roughly to 90 degree and making sure that the heel are at the same level. So just use edge of your index finger to bring the heel to the same level. Now first put the hand in front of the tibia. So if there is any shortening, say for example if it was like this, that means the femur is short. So when you're putting the hand on the tibia, you are assessing the femur. When you're putting the hand on the femur, and if there is any difference, then you're assessing the tibia. I've also uploaded this video separately, so you can watch that to gain more insight onto it. Now, if, for example, if you have shortening in the femur, then there is one important test that examiner, they love it, and they love it everywhere in every country. That is what we call as a Bryan's triangle. So what is Bryan's triangle? First, I will show you on this model, and then I will show you on the board to make it more clear. So this is your ASIS, this is your GT, and I have told you earlier how to feel for them. So draw first line vertically going down the floor. You can draw the second line from tip of the GT and the third line joining them. So this is what we call is a Bryan's triangle. I think it's quite clear, so we might just stick on here. Now, if there is supratrochanteric shortening, say for example this is your GT. If for any reason GT becomes up, if you compare from the normal side, this line will become narrow, or the distance between tip and this will become less. So this will tell us if there is supratrochanteric shortening. Sometimes in DTH, if the trochanter is, say for example here, then it becomes a reverse Bryant's triangle. So this is the importance. This line tells whether there is a supratrochanteric shortening or not, and you should know about what are the causes in which you will see supratrochanteric shortening. So this is the most important line. Now you have got two other lines as well. This vertical line. Now this is dependent upon the rotation of the GT. So if the GT is externally rotated after any fracture, or if there is any FFD, then this line will become more. However, if due to central fracture dislocation, if for any reason GT moves inside, this line will become less as well. Now the third line is this hypotenuse. So the hypotenuse, again, if the joint is going medially, trochanter will become closer and this will become shorter and shorter. So say for example, if somebody has got protrusio, if somebody has got central fracture dislocation, or on the opposite side, if you have increased the offset after a total hip replacement, then this line will be increased. Now the second line that examiners they love in India is shoemaker's line. So shoemaker's line is nothing but if you draw a line from GT to ASIS and then you extend it further, and that is your shoemaker's line. Normally, if you extend the line, they will meet in the center and they will meet in the midline, usually either at the level of umbilicus or above the level of umbilicus. However, say for example, this side, the GT has become up. So instead of the line becoming like this, the line will start, because of the upriding of the trochanter, it will meet on the opposite side and it will meet below the level of umbilicus. If you have got bilateral pathology and they are symmetrical, in that case they will meet in the midline, but they will meet below the umbilicus. So this is your importance of shoemaker line. Now the third line which the examiner will often ask is, which is the line that you will use if there is a bilateral pathology? And the answer to that is Nelton line, and I will show you what is that. So Nelton line is a line, if you draw a line from ischial tuberosity to ASIS, and as I showed you, ischial tuberosity is felt in this hip inflection of 90 degree and knee inflection. I have drawn it, and you can see on this occasion the tip of trochanter is either below or usually it just touches it. If there is supratrochanteric shortening and if this is upright, then what it will do, it will cut or the line will pass below the trochanter depending upon how much shortening it is. And you can assess both sides differently. So if the position at this point of time we are assessing the right side, but the same way if you turn the patient on to the right lateral, you can assess the left side. So you should know these three lines very well. So the second, the few more things that I would like to cover here is, one is the Chinese test or line. We talked about it in our deformity section. In that area you will see that ASIS was going up and down. However, if there is any supratrochanteric shortening or infratrochanteric shortening, if trochanter goes up in this, then the line will converge on the affected side. So as more trochanter will go up, the convergence will become more and more. So this is, we have talked about it. Now the second is, sometimes examiner may ask is, what is Morris bitrochanteric test? So this is a line when you draw from GT to pubic symphysis. So in a normal patient, if this is A and this is B, A should be equal to B. However, for any reason, if this hip is medializing, say for example there is protrusio or there is central fracture dislocation, then this line will become shorter and shorter. In that case, A will become greater than B depending upon how much this has medialized. On the contrary, if for any reason after fracture there is external rotation of the GT, then the line on the affected side will become more. So you should know about this Chinese line, Morris biotocontric test. But the most important question they will ask is if you have bilateral pathology, then you should know the Nelton's line and how to draw it. So few things that I would like to cover in measurement is we need to talk about segmental measurement. This is also a part and parcel of true leg length measurement. So you need to fill up all the prerequisites, and that will be squaring the pelvis and both the legs in identical position. Now I have told you how to palpate ASIS. I have told you how to palpate or feel the crest of the medial malleolus. Joint line, I keep my finger on the medial joint and I just move it. This is the easiest way I find, and I have drawn a medial joint line here. So to do a differential or segmental measurement, first you measure from ASIS to the medial joint line, and then from medial joint line to the crest of the medial malleolus, and then you can compare on both the sides, and then it will give you a reading. The last thing that you want to measure is measurement, or which you call a circumferential measurement as well. Now circumferential measurement is usually to assess the wasting of the quadriceps, which is common in hip pathology. So how do you measure it? So you need to I take around 15 centimeters from the tip of the patella. Use any fixed bony point, and say for example this is 15, and say for example this is 15, so it has to be the same side, and we choose an arbitrary 15 centimeters because this is the point usually where you will see majority of the quadriceps bulk. So once you have done it, identified a bony point, take a measurement and compare both the sides, record it and tell it to your examiner. So once you have done your circumferential measurement, sometimes examiner may ask you a question that which component of the vastus quadriceps gets wasted first. So it's usually the vastus medialis. So once you have completed the measurement, then we move on to the special test, and before that we will tell you the test for hip stability. So let's now start with the test of stability. I think the first test, that is a very simple test, is what we call is a straight leg raise. You ask patient to raise the leg, and if he or she can raise the leg up to around 80 to 90 degrees, then that is a negative test that tells that the femoral hip joint is intact, stable, and it virtually rules out any fracture. Now the second test, which is extremely commonly asked and it's favorite for examiners, is what we call a telescopic test. Now telescopic test is a test which is to check the intactness of the femoral neck to femoral head and its relationship with the acetabulum. So you must know the femoral telescopic test because it's a very useful test and commonly asked in exam. So say for example, we are examining the right hip. So in order to do the telescopic test, first you need to bend the hip to 90 degree and also the knee to 90 degrees. So hip and knee flex to around 90 degrees. And if I am examining the right hip, my left hand will be used to feel the telescopic part. On to feel, you have to have your thumb on your greater trochanter, which we have already palpated before and marked, and the fingers on the bottom. And with the right hand, so if I am examining the right hip, with right hand I am pushing and pulling. So if there is a femoral neck fracture or the hip is dislocated, then there will be no firm end point, and that would be a positive test. Now remember, there will be slight few millimeters of telescopy anyway present in the normal joint, but if the joint is unstable and hip it out, you will feel that there is no stable firm end point and it will be soft, and sometimes if it's a native head, you can actually feel the head on back of your hand as well. So the third important test for hip stability is Stendelberg test, and which we have already covered in the gate. So you should know the Tenderloin test in and out. And the fourth test for hip stability that we used in pediatric patients for DDH is called Otorani and Barlow test. So I'm not going to demonstrate you how to do Otorani or Barlow because I don't have a kid and it's very difficult to demonstrate in an adult, but you must know about what is Otorani, what is a Barlow. So Otorani is usually a reduction test and Barlow is usually a dislocation test. So you should know about it. Now, once you have done these tests for stability, there are a few tests that you should also know in hip, and I'm going to teach you some of them. So the first test that I would like to teach you is what we call is a test, Craig test, and this test is used to measure the anteversion clinically. So it's a very easy test. So what you need to do is first bend the knee to around 90 degrees and then put your hand over the greater trochanter and move greater trochanter in and out so that you are confident that you are feeling the greater trochanter. Now, once you start rotating, then stop where you feel the greater trochanter is most prominent. For me, this is the position in which I am feeling the greater trochanter to be more prominent. Now, if this is the most prominent bit, then the angle, if this is a vertical line and this angle formed between the leg and this vertical line is the anteversion which will for this particular hip. So this is a very useful test to give you a rough assessment of patient's hip anteversion. So the other test which examiners can sometimes ask is the test for tight rectus femoris, which is called Ellis test. Now Ellis test is a very simple test. Now what you need to do is you just need to test both the legs to have a normal comparison and bend the knee and then bend the knee completely. Now what will happen if the rectus was tight? Now because the rectus is tight, when you bend, you keep on bending the knee, what it will happen is the patient will lift the hip up because the rectus is tight, and because of the tight rectus, to compensate, the patient's hip will move up, and if the patient's the hip moves up off the couch, that is a positive test suggestive of tight rectus femoris. So the other test that I would like to tell you, which sometimes you may be asked, is what we call as an Ober test. Ober's test is to check if your TFL, tensor fasciae lata, is tight or not, and it can also be sometimes seen in external snapping. I have uploaded a video of Ober's test separately, so if you want you can watch that as well. But in Ober's test you get the patient lying on their side and this is the affected side. So if I am examining the right side, the patient should be on left lateral, bend the knee up to the 90 degrees and then hip slightly extended and then let the leg down. In this case this is normal patient, so you are able to adduct it. If it is tight, it will feel like a bowstring, and even if you want to put it down, it's not going to go down. So in a normal patient, this will adduct easily. If the test is positive, it will be tight and you will struggle to adduct the leg or thigh. So the last sign that I'm going to cover in a special test is Gowen sign. Now this is a very common thing which is asked in India, not so common in England or Frcs because tuberculosis of hip is rare there. So this is a sign for early TB, and what you do is, if patient is lying supine or lateral, you just suddenly move internal and external rotation of the, so if you suddenly move the hip into internal and external rotation in a positive test, you will see contraction of abdominal muscles and adductor muscles due to pain. So if there is any contraction of adductor muscles and lower abdominal muscles, that is a positive sign seen in early tuberculosis. So this was a demonstration of hip examination. Now there are a few other things that I would like to cover, and one of them I feel is extremely important, which is called hip impingement. Now hip impingement is commonly appreciated and it's a very common diagnosis in orthopedic clinic. However, in my experience of working in India, this is still not part of differential diagnosis of many hip surgeons as well. So I will show you few tests if a young patient presents to you with a hip or a groin pain, and if you're thinking hip impingement, then I will show you few tests as how to diagnose it. Now, hip impingement is usually seen in young patients, and they will complain of pain in the groin, especially if they are in extreme of the movements. And in India, it's quite common. Patient will report a pain while squatting because that is an extreme movement. So the first test that I am going to show you is what we call is a FADIR test, that is FADIR, FADIR test, and the test is very easy. So what you do is flex the hip, adduct, and then internal rotate and look at the patient. If the patient has got hip impingement, they will complain of pain and discomfort. And if it reproduces their symptom, that is a positive test. So the FADIR test is for anterior impingement. For posterior impingement, we do what we call is a Faber test. So flexion, abduction, and external rotation. So in this position, if it reproduces patient pain, then that is a positive test for posterior impingement. So the last test which I will describe is you will not find it in the books, and I learned this test from Professor Richard Field, who works in Epsom and is a hip surgeon and does a lot of arthroscopies, and he learned this test in Israel. So we called it what we call an Israeli distraction test. Now the same test, the FADIR and the Faber test, if you repeat the test by bending the knee in this position and then distracting it with my elbow. So I'm just distracting it with my elbow and then doing the same FADIR and Faber movement. So what it does is, if the pain which was seen before on this distraction in the same movement goes away, then that is also a positive test suggestive of a very high chance of impingement and plus minus labral tear. So the next condition that I would like to cover is what we call is a Piriformis Syndrome or deep gluteal syndrome. These are the patients who will present with sciatica-like symptoms, that is pain and radiation going down their legs. And it can be quite confusing whether it is because of a lumbar disc or it is because of Piriformis syndrome. Now some surgeons, they believe that Piriformis syndrome actually doesn't exist. However, if you see a patient in your clinic who you have examined, who you have done an MRI is normal, but still they are having sciatica-like symptoms, then there is a good chance the patient has Piriformis syndrome. So these patients will present to you with sciatica-like symptoms. Usually they are unilateral, they are not bilateral, and they will tell you that they cannot sit for more than 20-30 minutes, and then pain becomes quite disabling and quite excruciating. So the one test that usually helps in making this diagnosis is what we call is a FAIR test, and I will demonstrate you how to do this test. So to do the FAIR test, the patient has to lie down on unaffected side. So we presume this is the side which is affected, and this is the side which is unaffected. So patient should be lying down on unaffected side. Then you bend the hip and knee to 90 degrees. So hip bend to 90 degrees and knee flex to 90 degrees. Then you slide to adduction, and then in this position try to do internal rotation. Now you put one hand on the pelvis so that pelvis doesn't move. So you do internal rotation as much as patient can tolerate. So what we are doing in this position is these external rotators, we are stretching it. And if the sciatic nerve is compressed there, if it reproduces the patient's symptoms in this position, then that is a positive FAIR test. So a FAIR means flexion, adduction, and internal rotation. So this is how you do the FAIR test, and if it reproduces the patient's symptoms, that is a positive test for Piriformis Syndrome. Last condition I would like to cover is snapping hip. Now, snapping hip can be external or can be internal. Now, external snapping is due to rubbing of IT band over the greater trochanter, and internal snapping can be broadly classified or subclassified into two. One is due to rubbing of iliopsoas tendon over iliopectineal eminence or over the femoral head, and the second is intra-articular snapping due to labral tear. So I'm going to show you a few tests which can be useful while diagnosing these conditions. External snapping is the most common out of three, and as I showed a while before, you will have a positive Ober test. So usually tensor fascia lata is quite tight, and if you a lot of times patient will be able to reproduce, and he or she will show you in the positions in which he or she will feel snapping. So diagnosis is quite common. However, if you external or internal rotate in different degrees of flexion, you should be able to reproduce that snapping. So this is how I diagnose external snapping. You will find that Ober test is positive, and you will be able to reproduce snapping clinically. Now, the easiest way to diagnose snapping due to psoas tendon is you ask patient to bend both the hips as you would do in a Thomas flexion test. And if you are having snapping of the left side, you ask patient to slowly extend the leg. And in this position and go straight completely, you will feel an audible click, or patient will say that this is what I feel. So again, flex it and then ask the patient to extend, and you will feel a click, and that is how you will diagnose internal snapping due to psoas tendon. Now, intra-articular snapping due to labral tear, you will have the test for impingement, that is Fadir and Faber test will be positive, and also the distraction test. When you distract it, then you will find that it's not causing pain that much. So this is how you will differentiate between three snappings. So viewers, this was a demonstration of how to do a hip examination, and if you follow the principles, especially if you are appearing in any form of orthopedic exam anywhere in the world, I can guarantee you that you will pass without any problem. If you like this video, please give us a thumbs up, do share it with your colleagues, do subscribe, and do share our channel. Thank you.